Pledge allegiance. Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Okay. Do we have minutes to approve?
Chairman, the next item on the agenda is an environmental health update.
Oh, sure.
We do have a
Jason? Oh, by all means.
Easier to see everybody. All right, so thank you. For those of you that don't know me, my name is Jason Pepin, Division Administrator for Environmental Health and Preparedness for Panhandle Health District. I've been employed with the Health District for 20 years. And although the agenda says I'm going to give an overview of the environmental health programs, really wanted to kind of use this opportunity to go spend a few minutes to give an overview of one very important program within the environmental health section for Panhandle Health District, and that's the septic program. And really just wanted to give a big picture, 30,000 foot overview of the septic program. Part of that just to kind of just build awareness through the Board of Health. Part of that for the purpose of, as we're confronted with big, large scale, complex issues, that we can start to, drill down into these specific issues and then work with the Board of Health members to gain insight into unique approaches that work well within each county. And this is also a very fundamental program for Panhandle Health District and really all of our communities as a whole. There's many reasons for that, but it's just some basic information. We issue more septic permits than any other health district in the state of Idaho, more complex septic permits than any other health district in the state of Idaho. We have very challenging site conditions. And so it's very foundational program for the health district and also our communities as a whole. So kind of with that, just wanted to give a real brief overview of some of the aspects of the program. I think everybody has a general understanding of septic systems and that it is, essentially the wastewater disposal systems. It's important to remember that septic systems are a fundamental utility for any property that's not going to be connected to sewer. Most of the septic permits that we issue throughout all 5 counties within our jurisdiction will never have the opportunity to connect to sewer or very unlikely to connect anytime soon. So it's really important that we, as a health district, that we're diligent, effective in our jobs, and then also work to educate property owners to ensure long-term use of these systems so that they function properly. With septic systems, one of the other really challenging aspects of the program is that we have to rely on site and soil conditions within each property to treat and dispose of wastewater. It's a delicate balance really between treatment and disposal. In a lot of the trainings that we give, we have slides showing, kind of scales of treatment and disposal. And it's important, property owners often think of it in terms of disposal where they, do a load of laundry, flush a toilet or whatever. It's important to not have water backing up in the home or surfacing on the property, obviously, but it's also important at the community scale that we also get effective treatment out of that so that we're protecting groundwater and surface water. The other unique aspect of this program in Idaho is that it's really a delicate balance of property rights for the individual property owners that own these properties and also, protecting ground and surface water. That's something that we're very aware of, very sensitive to, but it is important that we do protect these resources because over 95% of the residents of Idaho rely on surface water as their primary drinking water source. And then just preservation of water quality in general from a surface water quality standpoint is important to all of us. That's, many of the reasons that people are moving here or that we enjoy living here is because of the high quality of water that we do enjoy. So it's really important that we preserve that. And, the septic program throughout Idaho, it's really a good representation of the state of Idaho. Just the way that the rules are structured, it provides a lot of freedom to property owners that, a lot of people that are moving here are very refreshed by that. But just like a lot of different aspects of life, with that freedom that the rules and the guidance provide, there is a lot of responsibility that's placed on the property owners. And so when we're most effective, really in any of the environmental health programs, but especially in the septic program. Yet we are regulators, as the environmental health program, we're the regulatory arm of the health district, but we're most effective when we can regulate through education. And that's really our goal, rather than just, hitting people over the head with the rule book. It's educating them so that they can use their property responsibly and, enjoy the use of their property and then not impact others. The septic program is also very critical within the inner workings of every county. We have 5 very unique and diverse counties within northern Idaho, and really this program functions best when we're tightly integrated together with the county processes, both from a land development standpoint, we're ensuring that the new parcels that are created are in fact buildable, and then also from the building processes within those counties to ensure that the structures that are built meet state of Idaho requirements, county requirements. It also is very critical for protection of both property rights and property values in the long term. So there's kind of a lot kind of mixed in with that. And so within that, we partner very closely with every county. And really, even though we essentially regulate based on statewide rules and guidance, there's enough flexibility within those rules and guidance to allow us to cater our processes to the unique demands of each specific county. This morning, for example, the meeting that we had in Benoit County discussing a lot of these issues is very different than the conversation that we had last week with the Bonner County Commissioners Workshop, or that we'll have next week with Cooney County Community Development. So really working within the confines of the county processors and also just the unique aspects of the county to cater both of our processes together to ensure success for property owners. One of the other dynamics that's been kind of a change over my career here is there's really been an increase in awareness at the decision maker level of all of our communities of the importance of septic permits and just septic systems in general, and ensuring protection of groundwater and surface water. And a lot of that just has to do with the sudden increase of growth that we've all experienced in these counties. For example, the number of septic permits that we've issued has essentially doubled from a time span of 2016 to 2021. It's just an indication of the general growth that we're all experiencing. And in this realm, what that does, that places a lot of strain on both the infrastructure within the counties. It's very common throughout pretty much every county that you can think of areas where we have sewer moratoriums, for example, as the expansion of sewer is not able to keep up with the demands of the development. Also seeing a drastic increase in property values over that time span. And that really, kind of creates this high stakes situations on every property that we're on. Most properties that we're on these days, start to finish, they could be looking at multi-million-dollar projects. So again, it's very critical that we work through this in a manner that ensures compliance, long-term functionality of the systems, and then preserves the property rights and the value for those property owners. Also seen a big increase in the number of big projects that demand the use of septic systems in especially some of the outlying counties. As we're getting bigger projects that outside of the standard individual residential applications to larger projects, and then having to work through the communities with those. And within that, again, we really focus on education, both at the individual property owner level, through the county commissioners as well. And the goal is to work through these situations that it avoids enforcement, because this is a regulatory program with potential both civil and criminal consequences for property owners that violate these rules. And so we just want to make sure that we're working through any of those challenging situations in a way, ideally that we can work towards solutions. Ideally, we're working towards win-win solutions with property owners so that we don't have to go through a formal enforcement program. That's not always the case, but the vast majority of the situations that we encounter, we're able to find solutions, get to that win-win type scenario. It creates incentive all around, and then to move past that without any need for enforcement. But again, we could spend hours going through individual situations that we're dealing with in every county right now, but we're bound to come up against future situations that ideally we're working closely with the Board of Health, both for your awareness and then also just so that we can work towards creative solutions together. And I did want to just touch on real briefly the kind of the funding of the program, because that is something that you're likely to hear from community members. And I just wanted to kind of explain the basis for where our fees come from, how the program's funded. So the septic program is largely fee-based. It's almost exclusively fee-based with a small percentage of county fund to support it. And it's important to understand what that fee goes towards. So within all 5 counties, the septic permit fee currently is $1,050. And so it's fairly common for people moving into the area to see that fee and to think that's high. Again, the fee is entirely, or that fee is entirely based on the cost of the program. But more importantly, most other states require consultants to do a lot of the work that we do. So for example, within that $1,050 fee, we'll go out, we evaluate the site. So we're actually, evaluating the soil and the site conditions on that site to both match the size of the septic system that's required to the soil and whatever those site conditions are, but then also the type of system and what would be required to meet Idaho rules. Most other states, there's a soil scientist that was required to do that. So in addition to the permit fee, so for example, if you were to get a septic permit in Spokane County, the fee for that is $1,600, but you would have to pay for a soil scientist to do the site evaluation, and then another consultant to design the septic system for you. Every single septic system that's installed in Washington and most other states requires a designer. Idaho does not require that, except for a very small subset of different systems, very complex systems. And so that's really where a lot of the fee comes from, is the work that we do that's handled by consultants. It's common when we teach real estate classes for people coming from other states to mention they may be looking at $5,000 to $10,000 in consulting fees for the same work that's done through our agency. And then also within that, though, again, that does give property owners a lot of flexibility to work through their projects, even to install septic systems themselves. That's something that a lot of other states do not allow. And due to the challenges that creates, that does take a lot of staff time. So there's a lot of our staff time that's spent, both educating on site, reviewing, going through, the site evaluation components of it, but then also following up on, if systems are not installed properly in other states, you would just have to call the consultant. The designer would come out. They would work with that installer to correct it. All of that time would be charged to the property owner. That's all still within our septic permit fee. So it's just important as Board of Health members to kind of understand that dynamic, because it is very different than some other states. There's some states where the fee is minimized. It's basically tax based, and so that fee is smaller, like in Texas, for example. But in Idaho, it is largely fee based, and then we have a lot of kind of work that we do within that. And so that's the main thing I wanted to cover today. I'm hoping that we can kind of expand on this and other programs in future Board of Health meetings, just to build awareness, education, and then also with the septic program specifically, you're likely to encounter people from your jurisdictions that may have questions or run into challenges. So I don't know if there was any questions.
Yeah, Mr. Chairman, actually, first of all, I want to thank you for your recognition of the balance between individual property rights and protecting the water supply, because it's the very foundation of our republic is individual property rights. So thank you for acknowledging that, because I've certainly met a lot of governmental entities who just say, I've got a job to do, this is the laws, heck with you, and I really appreciate your statement on that. From my understanding, did I hear you correctly when you said that Kootenai or the upper this Panhandle Health District issues more than all of the other as far as permits is concerned? Is that true than the other districts?
Not all other districts combined, but more than any other district. And for example, in Bonner County last year, we issued 486 septic permits in one fiscal year in one county. And that's more permits than several health districts issued for the entire year.
So in other words, it's a reflection of the rural.
Exactly.
Yeah.
Yes,
Okay.
yes.
I just wanted to understand that.
Yes.
Yeah. No. Exactly.
Yep.
And then this kind of surprised me a little bit. I'm just kind of used to wells. I mean, so you said a really high percentage of people get their water from surface water. Is that correct?
I hope I didn't. It's groundwater. I apologize if I said that wrong. So It was more than 95% of residents get their drinking water from groundwater supplies.
From
Sorry.
ground?
Yes.
What does ground mean? Does that also mean
Wells.
wells as well?
Primarily
Okay,
wells, yes.
I thought you were saying surface.
Yes.
Okay, got it.
And I apologize if I missed.
No, no problem. You probably said it correctly. I just that's why I wanted clarification. Thank you.
Okay. All right, well, thank you. There's no other questions?
I'm fine, thank you. I mean, it's
Yeah, thank you very
commendable
much.
work.
Yeah, thank you.
All right.
We're on number 4.
Right. Commissioner Cassidy, can you hear us?
Yes,
You're
yeah, can you,
on the docket.
okay, I apologize, I do not have anything for today's meeting. However, I'm looking forward to, next week's conference and getting in touch and making connections with a lot of the other trustees.
There's no apologies. Quite frankly, that's appropriate. I mean, you'll have, after next week's meeting, then you'll actually have something to report on. So that's okay.
Yeah.
All right.
Okay.
Plenty fine. So now we're moving into item 5, consent agenda. I don't know if you want to go through these individually. I mean, does anyone, the way I deal with consent agendas is sort of, is there something on this list that you would like to extract? And we can talk about the extracted ones. Otherwise, we can vote on the entire consent calendar, including staff. Are there any minutes or any of these items you want to extract? And we have plenty of time. We're well within our hour limit, by the way. Well, this is going to be a short meeting. You anything you want to pull out? I mean, the minutes or whatever. I looked over them. I thought they were fine.
Yeah, Chairman, this consent agenda did build up somewhat due to lack of quorum in prior meetings, so it did. But
I got it, but we don't.
I don't have anything specific.
As it relates to the fiscal report, what I sort of wanted to do is every quarter we'll have a detailed. Otherwise, you've got the paperwork. People can be expected. Board members are to be expected to look at them, and if there are issues at hand, you're here and we can talk about them. Yes. But so when is the quarter where you'd be coming on board?
Chairman, we hadn't
Talk about that.
nailed that down particularly,
That's
but
fine.
frankly, we can do that at the discretion of the board when they would like to see those.
Yeah, once a quarter. So 4 times a year, you'll have your more formal, and of course, once a year, you'll give the whole rundown and are we broke or.
So ideally, that would have been last board meeting in September.
Oh.
We would have presented a quarterly report, but again.
Well, we have the time now. Are you prepared to give it, or I don't mean to put you on the spot.
I appreciate that. I'm really not quite prepared, but what I can say is, because it's so early in the fiscal year, things are somewhat distorted in the fact that maybe we paid annual premiums in advance to where we're seeing some over budgets in certain line item categories. However, as we progress through the year, those will flatten out. We really haven't gotten into the program deliverables yet. We'll start seeing more activity towards the middle to the end of the year. So because this is only a 3-month report, it really isn't reflective of our financial performance. However, what I would like to do is carve out time next board meeting to discuss the fiscal year end 24 financial report, to see how we ended fiscal year 24. And if we have time at that point, and depending on what our months in reserves are, I may propose that we move funds from the general fund to the board committed fund. We did not do that last year. We have not yet done that this year for fiscal year 25 because the reserves are not where I would like them to be to move funds. And the reason for that is primarily due to the Luma conversion. We're still getting payments in that have been billed months ago because of system limitations. Nothing on our part, but on the part of other agencies in how the receivables were processed on their side. So, excuse me, when we get to a point where we have excess, a consistent excess in months in reserves, I do want to move funds over to board committed funds.
Okay,
Any questions?
I have none, but the next meeting, you're gonna be on point.
I can be on point next.
Okay. Perfect. And you can catch up, we'll catch up. Perfect. Any other items we want to extract? Well then, shall we take a motion to approve the consent calendar?
I'd like to make a motion to approve the
Do
consent.
we hear a second?
I'll second that.
Any objections? Hearing none, consent calendar is approved. Director?
Thank you, Chairman. I simply have 2 items to discuss this afternoon. One is an update to our Board of Health subcommittees. We've made some headway with regards to selection of new legal counsel. We are looking at this time at 2 groups, the Davalier Law Group and Lake City Law Group. Interviews with those 2 firms are scheduled for October 30th and November 1st. And the subcommittee, I believe, is largely available to be in full attendance at those meetings. We have yet to schedule, I believe that's something, Chairman, I need to work with Jessica on, is to get meetings scheduled for the consulting physician medical director subcommittee. So we'll reach out to those subcommittee members and get a meeting scheduled for the coming meeting. That's all I have on the subcommittee.
We've got 2, well, we have all 3 of us here.
Well, there's one
It's
more too.
imperative that the 3 of us are on that, we speak.
Yeah, I think, wasn't Glenn on it as well too? Yeah, Glenn is on it as well too. But it'll be really helpful if some way we can review what other health districts are doing so we don't have to reinvent the wheel.
Well, I've started that.
Oh, you have? Okay, good. I hadn't heard anything, so I just want to make
Right,
sure.
well, I've started that, and
Good.
what I've discovered is it's almost none. In other words, the arrangement we have with the Kootenai family outfit, which is really a perfunctory relationship. All he does is rubber stamp whatever prescriptions need, a medical license to make legal. Otherwise, there's no active input on the part of the medical director in regards policies, in regards services rendered. There's no other input, and that appears to be the pattern of all the health districts, as best I've discerned up to this point. I've not heard back from everyone.
Okay, so in other words, what are they rubber stamping? What does it come from? What is the?
Well, let's go ahead.
I mean, there's local immediate needs. I get that, but I'm talking about in the bigger.
Yeah, so, Mr. Chairman, typically we just have our standing orders. Those are drafted in-house. We have our nurse practitioners that all review those and sign off on those, and then those also go to Kootenai Health for their review. So Dr. Chase, I don't know if you are familiar with Dr. Chase. She is a physician at Kootenai Health Family Medical Residency Program.
Oh, yeah.
She comes here on site twice a month. So every other week, she's actually seeing patients here in our clinic. She is a family medical physician, and she also brings a current resident physician with her. So it's really a training opportunity for the medical residents to come here and experience public health. So she's provided a lot of
Support.
yeah,
help,
yeah,
et
she
cetera.
really does. You know,
Exactly.
she when she started coming to the health district, we didn't have any controlled substance policies. we have nurse practitioners here that see patients. They weren't really comfortable prescribing controlled substances. And when she started here, you know, as well as I do, I mean, mental health is a challenge. So we have people coming here with ADD, you know, people needing stimulant therapy, people, you know, needing anti-anxiolytics and things like that. So she actually brought in the policy that Kootenai Health had regarding controlled substance that actually put a procedure in place.
Good.
Contracts with the patients, behavior expectations, such as, you know, if you want to refill on a narcotic, you have to allow us 5 business days to refill that. You know, there's just expectations. It really clearly laid out the expectations there, possibilities of drug testing and things like that. So she's really helped a lot with some of the policies that we've had in place. But I'll be honest, when I started here, clinical services really didn't have a lot of policies in place, or if they did, they were, I would say, just kind of on a Word document. These aren't our policies that are officially like on paper. So we've really started the process within the last year of pulling that kind of information, putting actual policies in place, simple things, how to manage the autoclave. I mean, there's just things that didn't have a formal policy in place. You got it.
Yeah.
So we're really working pretty hard on that, but she has really assisted a lot with review of those, as well as some of the presentations that we have, you know. Epidemiology is always taught the sexual reproductive health classes in schools. We've revised that presentation this year. We've pulled out a lot of the graphic images, you know, really talking about, you know, talking with your parents about this. So we're kind of changing the direction that has gone, and she's reviewed all of those presentations as well, which I'm so appreciative to have an MD review of those kinds of things and her perspective.
No, I think that's wonderful, and that was just my concern, is that there weren't policies, there weren't, you know, guidelines. It's almost like, because that's sort of the charge, I think, to a certain degree of the health district, to provide some of those guidelines, and I think when larger events happen, people just immediately gravitate to, well, what does the health district recommend? Oh, we don't have any recommendations for you. Or wait, let me dial up and find out what works.
So that would probably be a little bit of a different situation. So I think we're talking like clinical services, day-to-day operations. We're talking, you know,
a larger picture, and exactly. See, so and that's where I was thinking, is that we're not necessarily. I mean, I mean, something that's functioning well, let's not reinvent the wheel, but at the same time, I think there needs to be perhaps a greater picture, so that we're not just, because different parts of the country have different needs, different patients, different demands, and, you know, someone in, you're not going to treat necessarily the populace of downtown New York City the same you would treat the populace in Alaska or whatever. I mean, you know, so in other words, I think there needs to be some locality to the medicine decisions behind what is done at a more of a global level. You know what I mean? And that's where I perceive that we need to open up discussions, that we're just not saying, well, what does somebody else tell us we should do? No, let's be local. Let's you know, we've got enough background and knowledge where we can make decisions that are very scientific and appropriate for here. You know, so that's what I'm hoping, that somehow we'll be able to open up or create or establish, you know, some types of guidelines that are more locally oriented, and we'll learn through that process, if that makes any sense.
Jessica, any thoughts?
What he said.
Echo what he said. Well, I'm going to be in a position next week to pin down a lot of the other chairmen and directors. I've not received a huge feedback in my email communications. In fact, to the contrary, very limited feedback. I don't know how to interpret that. It's sort of irrelevant. But I'm going to have these people as a captive audience next week. And my task next week will be find out what the role of a medical director and how other districts are working. What do they have? Okay. Then it may be the case that the subcommittee needs to just meet and brainstorm. Frankly, we get in the same room for about an hour and kind of figure it out, and appropriate staff too. I mean, I think this is a collective effort.
Absolutely.
And then just begin putting down thoughts. What do we want? Organize those thoughts, exercise what the role of a medical director would be with outside parties. I know Commissioner Duncan is interested, and other individuals. And then we may have to create sui generis. It may have to be our own creation, quite frankly.
Well, and to be a pace setter for other districts, that maybe we can help them, create a pathway that at least they've got a guideline that they go, well, we like this, we don't like that, but at least we're all moving forward rather than just stagnantly going from a reactive point of view than a proactive. It just doesn't make any sense to be reactive.
Well, and I
We've said this before, and I want to repeat. I have no intention of undoing what you have already established. That's not the point here at all.
Right.
It's really to
Yeah,
draft
I
on
don't
top.
have any concerns there. Like I said, there's nothing that's like hidden or scandalous going on in the clinic. You'd be
Right.
probably kind of bored with what you'd find down there, quite frankly. But I do think there's two aspects of this. There is the preparedness aspect that is looking at, again, from that global standpoint, a pandemic happens, what is the medical oversight? And then there's kind of clinical day-to-day operations. So I think when we're looking at a medical director, we're kind of looking at a multi-level situation here. It's, just kind of keep that
Right,
in
I
mind.
would agree, because
Yeah,
they
you
can't
said
be
it perfectly.
contradictory. Yeah, there's got to be some unity. Yeah, because different messages are confusing, and then everyone's lost, and then that loses respect and reputation, and that's not what anyone needs, for sure. No, that's great.
You have anything else?
Just that the second item that I had was an update on the Idaho Association District Boards of Health meeting that you, myself, and Commissioner Cassidy will be attending on next week, which will be next Wednesday and Thursday. In review of the agenda, a lot of it will be educational. It looks like we'll be meeting with a number of department heads from various agencies that the health districts interface with, as well as meeting with Seth Griggs, who is, we are part of the Idaho Association of Counties, and so there'll be some discussion on legislative updates and some strategic planning looking toward the next legislative session. So it looks like a reasonable agenda once we get to Idaho Falls. And I think it'll be a good opportunity to collaborate with our peers.
Yeah, I want to network. Yeah. Is that it?
That's all I have.
Anything else on the public comments? There's no public. Staff can comment. You guys can comment. You're part of the public. But just since we have plenty of time, Eric and I have been going to the different county commissioners and putting forth the message that Panhandle Health is looking to, I wouldn't say completely remake our image, but at least to bolster the image of public health in the community. We've had this conversation. This is not new news to anyone in this room. And I think we've been well received, actually very well received. We've had some good feedback. We're looking to hold town hall meetings. We're looking to approach different organizations, such as veterans groups, Elks Club, even political entities, like Central Democrat committees or Republican committees, different church groups. In other words, this is an outreach program that we want to go to the citizenry, and the emphasis here is to get feedback from the community as to what they expect from public health. Because oftentimes we're either forcing people to wear a mask or do the right thing with their leach field. And they don't like that because it costs money and it's bureaucratic hassle. But the truth of the matter is there are important things, very important features of public health. And then the objective here, we've talked about having a strategic planning meeting. We're looking to make our meeting, and this, everybody's invited, in May of next year. In May of next year, because this will give an opportunity for the state legislature to finish, and we will give a personal invitation to all of the participating legislators to attend this strategic planning meeting. So that project is moving forward, and to date, we're well received. In fact, Commissioner Duncan was in the office this morning, and we were discussing many of these issues.
Mr. Chairman, if I may, and I think one of the great opportunities of these meetings and meeting with these other groups is to really emphasize the good work that the health district has historically done. There's no doubt that you know, through the pandemic, there was messaging that could have been better delivered, and that in some cases certainly caused fear. But I would like, in addition to addressing that, to address the fact that fundamentally we're aware of our communities, as Jason, you know, spoke to, and we do have a lot of program that benefits a lot of people. And I think that it's just as important. It's important to seek feedback, to look toward the future of the health district, but at the same time, it's very important to emphasize there's a lot of good work that the health district historically does and continues to do. And I'd like as much of the community to be aware of that as we receive feedback.
Absolutely. Yeah, wholeheartedly agree.
Good.
Okay. Do I hear a motion to adjourn?
So moved.
Second?
I'll second.
You will. Hearing any objections? Hearing none, we're adjourned.
Get your, so,
Yes, sir.
after meeting with Commissioner Duncan this morning, I went